this morning. This is kind of the first official start of what we're considering our quote summer series for the GSTTP program. And I know you all really wanted to be out in the world right now doing projects and embedded in global settings. And because you're not out there, we're trying to bring to you a kind of a taste of what's out there in terms of the reality of global health research, but also our important partnerships and colleagues that we work with in various ways. So I'm really excited for this first session to have Thandaza Nkabinde. He is a family medicine doctor based at the University of KwaZulu-Natal, which is in Durban, South Africa. And he's had a really incredible career to date dedicated to urban health, to rural healthcare. So even though he's sitting currently, I think, in Durban, his heart is in rural South Africa. And he did much of his early family medicine clinical work out in rural settings and recognized a lot of challenges around medical education and training and what rural doctors, have to deal with. And it's not dissimilar to some of the situations we face in this country. The difference between working in LA versus being out, in Central California, in sort of places without a lot of infrastructure where referrals are very far away and you're quite on your own. He's getting his PhD currently and actually studying ways to improve medical education for rural doctors. He's also really passionate, directly supporting a lot of underprivileged youth, linking them to schools and education and mentorship. So really excited to hear from Thandaza about his work. And I think we really want to encourage you all to post questions in the chat during the talk. And then I'll kind of try to moderate if there's a moment where something, because I know Thandaza, you probably are not going to see the chat as well as you're talking. So if there's something really important to get you to pause, I might interrupt you to answer the question if that's okay. Otherwise, we can do just at the end. And the other thing I wanted to mention is that the site where Thandaza did much of his healthcare clinical work is in rural South Africa, affiliated with the family medicine department that he works at. And we send medical students there in their 4th year to do a 3-week clinical rotation. It's called Bethesda Hospital. And it's been a really amazing experience for students who have gone. And we, right before COVID, we're trying to arrange this very cool exchange and give scholarships for rural South Africans from this area to come to UCLA and pair UCLA students with the South African medical students. And of course that got kind of blown out of the water in the COVID world, but we're really excited to get back to that and build stronger bilateral partnerships with the family medicine department at the University of KwaZulu-Natal. So, we're really grateful for Thandaza and for the partnership and friendship that we've had. And I'm going to turn it over to you to share slides and take it away, or if you want to introduce yourself first and then share whatever works best.
Thank you very much, Lisa. Thank you for that introduction. And very nice to meet all of you. I know it's early morning your side, and it's late afternoon on my side. So quite exciting to even be speaking in different time zones. But yeah, looking forward to engaging with you further. I'm going to share my screen and we shall start. Okay. So I've been very excited to have been asked to basically just come and speak to you about my experience, or my personal experience of conducting research in the South African rural context. And I've certainly tried to keep this presentation as real as possible and not scientific at all. So excuse the lack of science in it, but please appreciate the emotion and personal touch that might be coming through as I present. Okay, so just in terms of an overview, I'm going to be just introducing you or contextualizing my rural community which I've certainly adopted, even though I didn't grow up in that particular rural community. And I'll give you a bit of reasons as to why one adopted that community as my own. I'll then speak a bit about doing research in that rural context, and further build it up with just telling you about my experience and what shaped my research interests, certainly with having been in that rural context. And then I'll just tell you a bit about my PhD journey, give you a bit of an overview of what my PhD is on, and then go into what are the processes that entail us having to do research, particularly in a South African context, but specifically a rural context. And then some of the challenges that I feel are faced, certainly, and how one has been able to overcome them. Yeah, and then we'll conclude from thereafter. So just giving you a bit of a picture of South Africa and rural South Africa in particular. So at the moment, I'm speaking to you from Durban. And basically, I grew up just inland in Pietermaritzburg, which is about half an hour from where I'm staying currently. But basically, I worked and lived in rural northern KwaZulu-Natal, which is just at the border of Swaziland and Mozambique area. And I stayed there for about 4 years, my wife and I. And we basically ran the hospital for a number of years and got involved in quite a few community practices up there. So speaking about this particular environment, we stayed in a town called Ubombo. It is in Umkhanyakude district in northern KwaZulu-Natal. It's got a population of about 110,000 people. And the area that is served by particularly Bethesda Hospital is one of the poorest districts in South Africa. And that was also one of our attraction to it. Certainly the poorest district in KZN. With a poverty rating of about 77.1%. And it has a high unemployment rate as well of about 65%. And I'm sure with the effects of COVID last year, that unemployment rate is probably sitting well over 75%, 80% at the moment. Close to about 80% of that population don't have access to piped water, any form of decent sanitation, or even formal housing. So it is extremely rural. But the amazing thing about this particular community is that it's able to stand besides all odds that it faces. And I took this picture, it was early 2019, and basically we run a rural health conference every year, where we go to different rural provinces in South Africa as just rural clinicians, and basically just share, some of our experiences, any research that we're doing, but also encourage many of the younger generation to be interested in serving these communities. And on one of my drives up to Bethesda Hospital in particular, and being in this district, I came across this tree, which I found very intriguing and very interesting. And this tree is actually called Umkhanyakude. So it's named after that particular district. It's a fever tree. And there's quite a history that's associated with that in terms of why it's even called a fever tree in this particular area. But what was interesting for me is it actually defined how the community that we found ourselves in was able to thrive besides all odds. And this is purely because, rural district hospital environments are often faced with multiple challenges, that go against any form of effective healthcare that we might be trying to provide. And yet, besides all of these, we see nuggets of excellent practices that actually emerge from these communities. And so just if you can imagine, this tree would started to grow about a couple of inches, but then all of a sudden died, but continued to grow even during those hard times, and then all of a sudden flourished. And this often happens in many of our rural hospitals, where for years on end, the hospital will literally be on life support. And all of a sudden, something happens or individuals come in and it starts to sprout up again, and life actually emanates from it. But even in those times of life support, it is able to survive. And so that just really defines the environment that I found myself in. Now, when we speak about doing research in particular in a rural community, it sometimes can feel like the blind leading the blind, because it is extremely difficult. It is difficult because of the multiple challenges that we are faced with. It is difficult because of the red tape that you have to go over. And I'll speak a bit more about that as I speak about the research moving on. And so many a times, I certainly found myself when I was physically there, living as if I was in two worlds. On the one side, if you can imagine this particular picture, I literally felt like an individual who was drowning because of the service delivery needs and just the environment that one finds themselves in and the pressures that come with it. And so trying to think about research in that particular environment is really hectic. But also what that then leads to is wanting to feel like you can just coast and not necessarily engage or involve yourself in the changes that need to happen within that environment. And so it is very critical for individuals who find themselves in such to start to think about what are the things that are important to us, you know, that we can glean to and actually get hope from. And certainly for me, that picture is a picture of my wife and kid. I thought I'd throw them in the presentation somehow. And I thought this was the best way. But basically, you know, I think working with my wife, Gloria, in that environment was very helpful. So again, emphasizing the need of support structures that are able to push you to be able to engage further in the type of research that you can be influential in that rural environment. And I think that then gives you a step. You know, you've got a way. You wake up every morning and you're able to actually think, I can face the day moving forward. And so this is critical. But with all of that said, we need to also think about a certain perspective that we need to consider. And certainly the big one with working in a rural environment and wanting to do research in a rural environment is, how does your research agenda actually fit in to the overall picture? And here we're speaking about the context we're finding ourselves in, a very difficult context. It is extremely rural, extremely underserved. Staff are stretched to beyond measures that you could even imagine because of just patient overload, lack of resources, lack of psychosocial support many a times. And so when you come with the research agenda, whose agenda are you pushing? And really, what difference is that going to make? And so for me, now being in the environment of the university and being primarily employed by the university, it is important, again, that I not just only consider the context that I work in, but also the research framework that I find myself in, because my employer will have a particular framework that I need to align to. And I think the question then is, does that also align to my research agenda as an individual? You need to think about the support for the research that you'll be receiving. Is that support adequate? Is it going to facilitate the change that you're wanting to see in that particular environment that you're finding yourself in? And then also managing research funding. You know, where are you getting research funding? Because it can be quite expensive to do research, in particular in rural environments, just because of proximity from, urbanization in particular, and then obviously the need to be able to find places to stay, travel, and etc. So who is helping you to actually fund that type of research? And then also, what policies are you following in doing your research? Okay. And so for me, all of this was very critical to be able to think about, and one had to really investigate what my employer thinks about the research interests that I might have. And certainly our university prides itself in wanting to be a premier university of African scholarship. By that, you know, they've said they want to see us being locally engaged, generating high quality research in and through the rest of Africa. They want to see us being innovative, breaking ground, not exclusive, but anchored within our own societies. And so they want to see us engaging with society in a way that helps to influence society to change. But not just that, they want to also see us engaging and collaborating with other stakeholders internationally as well. And this emphasizes the need for good research. That also, if I then take a myopic view into just even family medicine, because, you know, having or being in a career of being a family physician, I also need to take that into light, as in, so what do we want to see as family physicians? What is our motto? You know, what is our feeling around research, and especially in a rural environment? And yes, we want to conduct high quality research that impacts the lives of individuals and communities that we find ourselves in. And this also goes just beyond, you know, the supporting high quality service delivery that we expect to see in district health services and at primary healthcare levels. And of course, the primary healthcare and district healthcare services find themselves in about 80% of our rural communities. Okay, so this was very important that one aligns to all of this. So with this in mind, it then made it extremely easy for me to find myself in a Bethesda type of environment. And I'm just going to share with you my experiences that really shaped my interests in research moving forward. Now, Bethesda Hospital became our first rural decentralized family medicine training site. And this started off when my wife and I went up to Bethesda to practice as clinicians, and then obviously as family physicians at the time. Why Bethesda, you might ask? It has a rich history of influential medical practitioners who were clear role models, you know, and individuals who, like Dr. Kelly Gate, who really had done amazing things in that environment, and amazing things without much support in terms of when you think about research, when you think about, you know, innovation, when you think about infrastructure and so on. And so coming along such individuals was really something that spurred one on to want to get involved. Not just that, but also the history of individuals who had been there and had gone on to do great things in rural medicine. And individuals who certainly have a love for rural medicine, which we did. There was also a desire to support the improved standard of care within a rural setting, because then it becomes a flagship for everyone else to actually show that we can make a difference. It doesn't matter where you find yourself and where you're providing healthcare, but it can be excellent healthcare, regardless of the challenges that are there. And obviously with the understanding of the needs of a district health system, which is underserved, doesn't have enough resources, it was important that we start to facilitate that process in helping it to improve. And then hopefully influence the Department of Health nationally in the importance of having family physicians actually getting employed at these district hospitals and at the primary healthcare levels. So on entering a place like Bethesda, we were shocked, not that we didn't know, but all of a sudden, as soon as you interface with it, you start to be shocked by the quadruple burden of disease. You know, you start to experience the challenges that come with maternal and child health, which is a system, again, where there's a lot of mortality. And when that mortality happens, a spotlight is shown on it, but there's not much support that is being provided to such environments. You're dealing with a disadvantaged and marginalized rural community that has inadequate healthcare resources and service delivery. And that, again, not that we didn't know it, but it strikes you even further, because now you're in the thick of things and having to really work through how do you improve these services. And unfortunately, that leads to lack of retention of medical staff within that setting, because anyone will want to move away and find greener pastures, if I can say. So a research agenda is literally the last thing on your agenda when you're entering into such an environment and when you are immersed into such an environment with everything you're having to deal with. But it is the one way that we can certainly improve the services that are provided to that area, because if we document what is happening, it then shows the changes that need to happen. And so it is important that we continuously were thinking about it, even though we were dealing with many of the aspects of trying to change and better the healthcare and the quality of healthcare that was being provided. And so when we arrived, then on average, you find that it's an environment with about 10 doctors who are clearly stretched and fatigued. And you know, these pictures certainly, I hope, highlight that, especially with the picture at the bottom. This was the picture of doctors every morning. because it's one doctor servicing 220 bedded hospital in the evenings alone. And the second on call doctor is possibly at home coming out for cesarean sections or emergencies, but this person is fatigued. And so there's no time to be able to engage in any other activities. And so they're doing shifts of about 24 to 34 hours on any time, which then becomes really difficult. But we found individuals who were extremely dedicated and had done a phenomenal job, even with the lack of manpower that they found themselves in. So our main focus then was work along the team. Don't just come in as individuals who are wanting to focus just on research, but let's get our hands dirty. You know, let's work as if we are junior doctors within that environment. Get to know and understand the challenges as you engage in the practices that you find yourself in. Recognize the areas that need further development and improvement, and start to document them, and then do research later on as soon as you start to fix them. Okay, and really a willingness to put aside the qualifications in that manner. And fortunately, within a space of about 2 years, we were able to increase the retention and recruitment, managed to fill over 80% of posts, managed to fill the allied healthcare posts as well within the environment. And so that increases even the camaraderie amongst the individuals. It increases the way they start to even view their practice of medicine in that particular setting. And now you can start to think about wanting to push the research agendas to improve the services even further. Working on improving availability of resources is also a big one, because without resources, you can't provide adequate healthcare. So fighting with the individuals that need to provide such resources within that district level setting was also quite critical for us to do. Ensuring that our staff is also equipped in terms of being able to handle the emergencies that they face up with, making it fun for individuals. And so, you know, applying for grants to be able to improve the type of quality that is going to be provided in the setting was also very important. Planning emergency medical updates within the district itself and involving other hospitals also became something that is important, because the only way to improve educational function is if you actually include the individuals and make sure that they're getting some sort of continuous development that is structured and happening within the setting. Engaging with the universities, because this is the structure that really helps in terms of strengthening research, particularly for a rural environment. There is a strong link between government, especially in a South African setting, government and the universities. And so when you've got the backing of the universities as an employee of the Department of Health, and you say you would like to conduct certain research, they do listen to you. And so it was very important that we started to look for grants, even within the university and externally, you know, through the NIH services, to say, how can we get help and improve the services that we have? And then from there, start to engage in research that is appropriate. But in doing all of this, always remembering that we need to stay relevant to our communities, because it doesn't matter how we change the services, it doesn't matter how much staff we might employ, it doesn't matter how much research we start to want to do in these environments, we need to always stay relevant to the communities. And so engaging in community projects became very critical. Making sure that we are, you know, appropriate in the way we handled even the psyche of the community when they're coming into this hospital environment, which now is seemed to look like a beacon of hope, you know, was very critical in those engagements. And even taking part and being aware of community needs, and not just localizing ourselves within the hospital setting, but going out into the communities, because even from there, we start to identify certain projects that need to happen and become research projects that are outside of just the health system. So what are the social determinants of health that we're having to deal with in these communities, and what research agendas can come through from there? But also lastly, just in terms of the experience, never forgetting to have fun, because when you find yourselves in such environments, it is very critical that your staff is encouraged as much as you push them hard, and make sure that they're having as much fun as much as they have to work. And so that was also very important in keeping a community, because all the individuals who are there are far away from their homes, many of them 4.5 hours, 5 hours away, living alone in this environment and working quite hard. And so how do you start to bring a community of individuals that build a family that then strengthens even the work that is going to happen moving forward? So with all of these things, it then really led us to a point where we felt like we could contextualize the type of research that we need to do within this rural environment. You know, once the fundamentals of service delivery have been dealt with, we can now start to focus on what are the research achievements that we want. And so in the picture there, you will see myself, my wife, and then our two registrars. So Dr. Kelly Gate and Dr. Lungile Hobe became our family medicine residents. And basically, they needed to start to engage in detail on research that we needed to do moving forward. And their research interests came out of the issues that we were seeing within our communities. Lungile Hobe had a passion for communicable disease. And so she focused her research entities in that, and we supported her in that. Dr. Kelly Gate had a passion for seeing improvement in malnutrition. And so he focused his research around that as well. And then for me, the development of thinking about learning in this rural environment, because remember, I came in as a specialist family physician with this knowledge and education of the importance of continuing to be educated. But I wasn't seeing much of that because of the challenges that we were facing within that environment and the type of individuals who were working there. So it was a question of how do we start to improve that? And so for me, this started becoming a real great learning need and research or area of research and interest. But what is critical when one thinks about areas of research is I need to assess my positionality. And the big thing is I need to question my motives for doing that particular research. Now, for me, what I had identified in this particular environment is that learning to become this self-directed learner in such an environment was really a significant challenge for the doctors who were there. And yes, this was multifactorial because of the limited resources, the poor staffing, or even poor approaches, because they hadn't had individuals who would help in supervising them on even how they're engaged on a clinical platform. And then they had no understanding of how to become a self-directed learner. In a South African setting, there is a big difference between the undergraduate training, which really focuses on clinical work, and then the postgraduate training, which starts to introduce research concepts. And so for an individual who qualifies as a doctor from the undergraduate program, if they don't have the backing of further education, they're not going to have that ethos of wanting to engage in further research or even do quality improvement within the setting that they find themselves in. And so I really started to notice this paucity of self-regulation with really pockets of excellence. You know, and the pockets of excellence came in certain individuals where you wondered, but how does this individual thrive in this environment without much support? And so that really started to become a great interest of wanting to study that further to see how can we actually improve these services in this particular environment. And of course, because of the challenges that individuals face, you find that there is really a high attrition rate. You know, for those individuals who left, they certainly felt like there was internal and external factors that led them to leave. But I did suspect as well that many of them just lacked that ability to be able to engage with experiential learning within this environment. And so we needed to dig deeper into that to try to understand it so that we can prevent the high attrition rate that was happening in this environment. And then certainly personally, looking at my positionality again and my interest areas in terms of research, I am the type of individual who likes to ask questions, likes to ask the why question and try to dig in to understand exactly why something is happening. So coming in with that interpretivist paradigm, it was very important for me to do research that would help me to understand that moving forward. So now to give you an overview of my study then, which is really based around trying to improve the services or individuals who service the health, the rural health environments. my research question was just around how do medical doctors working in these environments understand their own learning and their learning needs? And the phenomenon that is being studied here is learning within a rural environment. And one approached it in, well, situating the whole PhD within the social cognitive theories, or the social learning theories, which were formulated by Albert Bandura and others moving forward. And thought that the best way to actually approach this is through qualitative methodology, all right, or qualitative inquiry, thus locating it again in this interpretivist paradigm. And the biggest approach was obviously coming through a phenomenological study, because of understanding again the individual's experiences that they found themselves within this environment. And in terms of the sampling strategies that we engaged, it was purposive sampling, really looking for information-rich individuals within this setting. So not necessarily going for all 15 or 20 doctors that are in that environment, but identifying individuals who are at different stages of their rural health practice, and then engaging with them on this overall question of how they understand learning in that particular environment. Now, there were specific objectives that one needed to come in with, and I had 4 main objectives in terms of investigating this phenomenon in this environment. One of them was, so what are their learning needs? The second one being, how do they actually learn within this environment? The third one was, how do they create learning opportunities for themselves when there's paucity, certainly, of learning in that learning environment? And then the last one is just exploring what they feel would facilitate the creation of an effective learning environment in that rural district hospital. So my data was collected in 3 phases, and all of these phases were linked to the 4 main objectives, with each objective building from the other. So the first phase was doing semi-structured interviews with 16 individuals in total. I chose 8 from Bethesda Hospital, and I chose 8 from Seleni Hospital, which is about an hour and a half away from Bethesda, so a couple of kilometers away. And these 2 environments are very similar in terms of function and in terms of individuals who had been in that environment. And the second phase of the study then just explored participant observation. So I spent time not necessarily as a clinician in that environment, but as an observer, and just walking around, finding myself in different learning environments, finding myself in different ward rounds, in different teaching activities, in handover meetings. If someone gets called for a resource, finding myself in that space. And obviously you can imagine this was quite difficult, specifically at Bethesda Hospital, because they knew me already. And so if I'm standing there and a junior doctor is doing a resource, there is that thinking process of, am I doing it correctly? And what is Thandaza going to say, you know, in the background? And so having to separate yourself and actually look beyond that meant that I needed to immerse myself really within that environment for a long time. And specifically choosing to not come in as a clinician was key, because as soon as I come in as a clinician working alongside them, it makes it difficult for me to really be able to observe how they engage with learning and the difficulties that it presents in this total environment. And so that was the second phase, and I spent quite a bit of time in both hospitals, literally just in the backgrounds many a times, where they really can't see me, and starting to niggle and investigate those particular areas that I found very interesting in how they approached their learning. And then the last phase was a focus group discussion after doing the observations and after doing the semi-structured interviews with all the interviewees, so all 16, and well, 8 for each hospital basically. And then having a discussion with them on, now let's talk about an effective learning environment. You know, I've observed you for a couple of months in this environment. Tell me, what do you think a picture looks like of an effective learning environment? And trying to build from there. I've chosen to not share the results of my study with you just yet, because I am in the process of writing my articles on it. And so I think you can certainly look forward to hopefully reading it one day. I'm happy to share the articles with Risa and the team as soon as they've been published, just to show you exactly what we found, which are really interesting findings, again, which hopefully are going to help improve the type of service and the individuals and how we train individuals within that rural environment. But now I just want to speak about the process that one had to go through in order to be able to attain and to be able to do this research, which is still ongoing. The first and most important thing is one needs to be affiliated to a higher education institution, even within a South African setting. Now, you can appreciate the difficulties of this for individuals who are just primarily working as clinicians in those environments, where, to then start to think about doing research is really far-fetched, because where are the universities? We've got 9 medical schools in South Africa. We've got well over 100 district rural hospitals in South Africa. And so how do those individuals engage with those centers? I had to register, obviously, for degree purposes if I'm thinking about doing a PhD. And again, let's talk about the difficulties and think about the difficulties that one has to face in order to be able to do that in the rural environment that you find yourself in. Finding appropriate supervisors, because they're not necessarily allocated to you. And there can be difficulties with finding supervisors. If you call and you say, sorry, I'm calling from Bethesda Hospital, which is in Ubombo, Umkhanyagute. And the academic might say, sorry, where on earth is that? And how are we going to engage moving forward? And so you need to be thinking about that in the processes of how you actually engage with research in a South African and rural context. Then the development and submitting of a research proposal is a critical stage, because this needs to be approved by an ethics body. And our ethics bodies are located within universities. And so you apply to them and you send them your research proposal, and they read over it to make sure that it is appropriate, and ethically is bound to the laws and regulations that govern us as a country. This also goes further, because you need to get approval from your local hospital that you're working within. So management needs to say, yes, I agree your research is important and it's something that's going to maybe make a difference. But currently, I'm sorry, there's only 10 of you as doctors. There's too many patients in OPD. I don't think this research is appropriate. And so you need to be thinking about those hurdles that you might face up just with getting local approval to be able to do your research. You need to think about provincial as well. As a district, you need to get approval. They need to see your protocol. They need to say whether the protocol fits into the government regulations as Department of Health and will be useful. And also, again, thinking about sometimes the issues that might come up of your research being seen as being something that will expose things that are not going well. And so you're facing that up as well at a provincial and possibly at a national level. But you need to think about the community that you're serving as well, because the individuals who are from within that community practice in certain cultural norms. And so when you come in and say you're going to be doing research, what is that research for? And so you need to be culturally appropriate in the research that you are doing and engage with them to make sure that they fully understand that you're not there to expose them, but you're there to help uplift the communities. And this can be quite difficult to deal with. Finding funding for all the costs that you're going to incur is also another challenge that one needs to go through. And so being presented with the different funding models is quite critical as a support structure to be able to do your research appropriately. And then the logistics around collecting data. How far you have to travel, where are you going to stay? Because there's no accommodation within rural environments. And I have very interesting stories of where I stayed because I wasn't now working in these environments. And it can be quite expensive if you're going to stay in one of the lodges. And so you have to find a place, especially if you're there for months on end, that is going to be, okay for you to stay, but be able to do your research. So you're going through those particular hurdles as well, hiring of vehicles because of the terrain that you find yourself in, and so on. And so these are all processes that one needs to get through as a process of trying to engage in research in a rural environment, and then plan for your data analysis and publications, finding the appropriate journals, and then the final submission in order for your research to actually now be in the public domain. So these challenges even lead into, well, I've spoken about some of these challenges in terms of funding, travel, community acceptance of your research. And the other big one is staff, in particular in the hospitals that you're going to be conducting your research. Remember, they are stretched to the extreme measure. And when you come in and say, I just need an hour of your time because I want to do a semi-structured interview with you, that time is stealing away time from their functionality during the day. And certainly after hours, they're extremely fatigued. And so how do you build confidence, again, in saying that what you are doing as a research topic is there to help improve the services that they're providing? And so this is a challenge that you have to engage with. Balancing your research and the other duties and responsibilities that you have is also another big challenge that one needs to face up to and be aware of on a constant basis. And then balancing your interests and other individuals' interests as well with regards to the research that you're wanting to do. And then the last part is really finding credible journals to publish your work, because it is critical for your work to be seen and for your work to be deemed as credible. You need to publish in credible journals, and this can be quite expensive, certainly in a South African context. And so that also comes into play as something that can be a challenge for many doctors or many clinicians to be able to publish their work. But I think the key things in being able to overcome some of these challenges is you need to be intentional. You need to have a plan and you need to have goals that are set out for yourself. You always need to think about the bigger picture of why you're actually engaging with the research you're engaging with, and what change do you want to see? What impact do you want to come out of the work that you are doing? I think that is very critical. So we're not just doing research for the sake of doing research, but we're doing research because we want to change something. And we need to try to link, and I always encourage individuals, try to link your research to your day-to-day job, because it makes it easier and it makes it enjoyable. Certainly if you enjoy your day-to-day job. You know, don't research something that is totally out of what you are engaged in, because just for the sake of publications, for instance. And so it's really critical to examine yourself and do a bit of introspection and self-reflection as to what interests me as a research topic, and who do I want to align to even in doing my certain research. And then procrastination is one of the biggest killers, certainly in research. Write. There are individuals who can always correct and help you with your work, but be encouraged to write and document things as you go along. And expect the unexpected, because that's how research is. You wouldn't research something that you knew. You research things that you don't know because you want to find certain answers in them. And certainly seek counsel from those who've gone ahead of you, because there's experience that is out there, and individuals are very willing to help in making sure that we facilitate research that will be influential as we move forward. And so in closing, I thought this would be very appropriate that in the research that we do, remember that research is formalized curiosity. And it's really poking and prying, but certainly with a purpose. I hope my presentation has helped, and I certainly hope that you have learned something from it. Thank you very much.
Thank you, Thandaza. Ooh, I'm frozen. I'm back. Yeah, that was incredible. You're getting lots of applause and hearts. I'm not sure if you can see that, but
I can see them. Yeah.
You know, when you and I talked about this a few weeks ago or last month, and you know, we just were kind of thinking through what to present, you just absolutely caught every piece that I think that our, you know, students, and even for me listening, so important. I want to open it up for questions from the students, which I think could be about pretty much anything: the research process, your project specifically, your career trajectory. Any questions?
Thank you so much for talking. My name's Tucker. I'm one of the students. I don't have any questions. I just want to say thank you so much for your time. It was really great perspectives, both on work in general, research, listening to communities, working with communities, and to get your story and some of those insights. So thank you so much for that.
Thank you very much, Saka. I appreciate that.
Thandaza, I just want to say a quick Good morning and good afternoon. And it's so great to see you and hear you. And thank you so much.
It's a pleasure, Lee. Very nice to see you as well.
And we have a date for Friday morning, your time.
Absolutely.
Great.
Absolutely. Thank you.
So Thandaza, it's so great to finally put a face with your name and to meet you, even if it's in the Zoom context. Really wonderful presentation that I'm so glad that we're recording it and we can share it with people that maybe are not part of this group moving forward. There's one thing that I'm really curious about, and I would love to get your take in the rural family medicine context. One thing that's really impressed me in reading student reflections who have rotated at Bethesda is the way that the physicians work with patients who have also been seeing traditional medicine physicians, and the humility and the approach to that, and the attempts to kind of work with people rather than work against. And I'm just wondering, how you've navigated that and how you teach that in the rural South African setting.
Yeah, thank you, Tracy, and very nice to meet you as well. Yeah, it's an area that is very critical, but is not given much attention, certainly in our undergraduate training programs. And it's an area that we've certainly tried to include, especially with our attachment where we place our medical students in a rural environment. Why I say this is because South Africa, as you will know, is certainly stuck between two worlds, especially with the urban and sort of rural environment and the disparities that are there, where we're training our students in more of an urban setting, and we're training our students in predominantly English, and in a culture that for many of them is not necessarily their own culture, if I can say that. And then we propel them into environments, certainly in their younger years, of where they're now having to deal with rural communities that have a different culture to them. And I'm even talking about Black South Africans who've been urbanized through the process of growing up and being fortunate to be able to go study in a university. When they interact with a Black South African in a rural context, which is majority 100%, they struggle because of the cultural norms that they now have to interface with and traditional medicine. We're training them in a Western certain way where the pill is the answer for everything. And then they get to an environment that is rural and a patient comes in and says, I've used that herb to try to treat this particular illness, and they dismiss it. And that's purely because of lack of knowledge. And so starting to really influence them in that sphere and starting to actually encourage them to start to think outside of the box and try to understand the patient. And so I often use a lot of examples of even during my practice, what I was finding. And I can just give you one, with malnutrition being a big killer in a rural environment. We saw a lot of kids coming in and the families have tried everything from traditional medicine, you name it. And when they would come into the clinical setting, because these kids were toxic, we often would say they had herbal toxicity, herbal ingestion toxicity, basically, which is causing them to die. But that wasn't necessarily the truth because there was underlying issues that the kids had. But we needed to know that because we needed to try and treat some of these herbal toxicities in terms of fluids or antidotes and you name it. And so I found that many of the junior clinicians would say to the mothers, did you give herbal medication? Which comes across very accusatory, comes across as you've done something wrong. But I would come through and obviously the mothers would say no because this doctor shouted at me and so on. And I would come through and would then start to engage with the mother and say to them, when last did you give herbal medication? Just by changing the way I'm asking the question, they're able to tell me the truth because they feel like there's a level of understanding of that the patient is within a certain culture and what they're doing is not necessarily wrong, but yes, it can cause harm. So how do we engage to be able to move forward? And so, starting to really train them on the way they need to be thinking around how they're engaged with the patients within their culture started to be a big thing. And so we've got assignments that we've given to students where we really ask them to go in and see the traditional healer, go spend a day with the traditional healer, let them consult, and you sit there in their consulting room, in their space, and you start to engage about, are you going to refer patients back to the traditional healer or not? Because you always think you're going to refer down to the sisters at the clinic and so on, but you expect the traditional healer to send you patients, but what are you doing about it in reverse? And so we're starting to really make them to understand that context. And it is proving to work, but it is still quite difficult. I hope I've answered your question, Tracy.
Yeah, thank you so much. That was really beautifully put. Thank you.
Pleasure.
Any other questions from students? You can type in the chat if you're not able to get on audio or video.
Good afternoon, Dr. Thandaza, or morning our time. Thank you for your presentation. I had two questions. My first one is that I read a paper that you did a few years ago, and it talked about internship training for South African medical graduates. And the paper you and your colleagues concluded that it was exceptional, but there were exceptions in terms of specialist training. I wanted to know, since the paper has been published and it's been some time, do you think that there have been a lot of advances made, in your opinion?
So so just to give you a bit of context, so that paper was done as part of my master's, and it was done at a time when South Africa was changing between a 1-year internship program to a 2-year internship program. Basically, the push for this was because many of the universities had decreased the undergraduate years of training from a 6-year program to a 5-year program. And so it was encouraging individuals to stay a bit longer in the clinical context, but still being supervised as interns. And so I thought, well, this is a great opportunity to actually assess this, because these interns will next year be in community service. And when you're in community service, you are thrust out into the rural environment to function independently from a year when you've been supervised, or 2 years that you've been supervised. And so it was critical to assess this, to say, well, does it really prepare them, for that year of community service? And certainly we found that in the basic day-to-day skills, it certainly did. But when it came to the more critical specialized skills, and especially things around, intubation, things around anesthesia and handling emergencies and anesthesia, handling, gynecological emergencies or obstetric emergencies, they were struggling. And this was purely because the experience that they were receiving in the internship was very guarded and guided. They wouldn't be put forth to say, you will deal with this emergency, but there was a registrar, senior registrar, and so on that would take the forefront. And so they would be observers, but not necessarily clinically skilled to be able to do the work that they do. Now, over the years, a lot of individuals did take that paper into consideration, and we assessed the training programs that certainly we had. But what we found was not that many people took much light to it. They still continued with the same training programs that they were doing, but we needed to then improve the community service supervision of these doctors coming in, because we knew they weren't as ready as they should be, certainly for the emergencies. So now the question was, how do we strengthen that side of things to make sure that they are, equipped and well equipped to handle themselves in those environments? So yeah, so those are the challenges that we found ever since that paper had been published, and some of the interventions that have been tried to help in the system.
Thank you. I'm glad to know that.
Thank you. And by the way, I'm really impressed you actually read that paper. So well done.
I took a class on maternal and child health in South Africa when I was in grad school. So when I heard you were going to speak, I was especially excited. And actually, that takes me to my second question. You mentioned maternal and child health presenting as a significant challenge in your presentation. And you spoke a lot about just like cultural sensitivity and working with traditional healers and the different examples you gave. Where do you see that possible overlap between maternal and child health and that ability to maybe send medical students to the traditional settings? Is that something that you think can be applied to that setting as well, and maybe improve the gaps in maternal and child health, the disparities that we see there?
That's a very difficult question, I must say, and quite a difficult one to even conceptualize in terms of how it would move forward as an implementation. And I'll tell you why, because there's a lot of regulations around maternal and child health in South Africa. And I mean, there's certainly a lot of training that has gone in to try to improve maternal and child health, especially for rural environments, because there are no obstetricians that are in those rural district hospitals. Again, it's young doctors who are having to deal with, placental accretors and placental previas and you name it, all those emergencies that would present. And so really, I think the stress that we've been trying to put in improving that care is not necessarily linking junior doctors.
Uh-oh, I think he froze.
Yes, they get exposure, obviously, as we place them in those environments. And that exposure is through, when they go out into those environments. So the obstetric units, for instance, going out into the community and working on a maternal obstetric unit in the community and doing delivery. So they get exposure to the high ends of maternal and child health and the importance of it and the importance of dealing with the emergencies and educating the communities. So we try from that aspect, but there hasn't really been formalized programs, where we're exposing them more and more. I think the focus has really been around how do we save mothers from dying? And the best way to save mothers from dying is not necessarily to focus on the junior doctors, but let's focus on the senior doctors who've been there for years and train them up, to be able to be skilled enough to handle what is happening in those environments and identify it to be able to deal with it. The junior doctors then get the support from these senior doctors. And so that's sort of the aspect that I think we're taking as compared to what we're doing with the traditional healers and the junior doctors and students. Because I think that one, as much as there's mortality that would come from it, certainly, but it doesn't strike us as big as maternal mortality, and the investigations that go into maternal mortality. And so the approaches have to be different in terms of how we approach dealing with it moving forward. Yeah.
So I know we're right at the end, but I just wanted to try to end with one last question for you, Thandaza. So speaking to the medical students here who are very interested in careers in global health, and many would like to work with a partner in Africa, Asia, South America, what advice do you have for American, US-based academic trainees and learners in terms of how to engage in global health in 2021, and what do you value in terms of partnership?
So I think the biggest thing is walk into it with an open mind, and don't walk into it thinking you're going to change that particular environment, because you need to have an understanding of that environment before you start to think about having interventions to change it. I know we are trained as doctors to be individuals who like to change things. We want to solve things. That's how we trained. But in an approach, especially in a global context, it's important to immerse yourself in that environment. Come in and say, I want to learn from you all. And through that, you'll find that you'll get more and more empowered to then actually have a long-lasting effect and a long-lasting impact in that environment. And I think that's a lesson that we certainly all can learn. And I'm not saying that I've been perfect in even doing that in my own environment here when we went into rural medicine, because you get in there and you think, I want to change things, but then you find that the environment changes you and changes the aspects and the thinking that you have. If you go in thinking you're going to change it from the beginning, you will be frustrated. And then you will not last long in that environment. So I encourage you to investigate it, investigate the environment you're going into, find out interesting things, get involved in the culture, stay in the communities, don't stay in the hospital settings or find the most urban place to stay in or, hotel or you name it. No, stay in the community, get to understand people and how they're living in that environment. And in that way, they will accept you and you'll start to actually know the secrets that are there as to how they live and how you can then influence change in that particular place. So yeah, I certainly hope that helps.
That's amazing. Great advice. And just again, want to say thank you with so much gratitude. This is just a phenomenal talk. And I hope you know that now that you've done this, we'll be inviting you back many times for repeat performances. And if the students have questions, we can connect you with Thandaza via email. And I hope that you have a wonderful evening there in Durban and everyone has a great day. And we'll see you all the students on the next session. All right, thanks everyone.
Thank you very much.
Thank you again, Thandaza.